Check, check.
You ready to go?
Okay, good afternoon. It's great to see all of you here. It's a pleasure for me to introduce Neda Rasooli to you. Neda, I think, in the past 8 years has given more Grand Rounds talks than any other faculty member here at the University of Colorado. And we keep inviting her back because she teaches us so much about diabetes. Neda is a professor of medicine in the Division of Endocrinology. She also directs the Clinical Endocrinology and Diabetes Trials Group and has done a terrific job in terms of bringing trials to the University of Colorado that are relevant to understanding how to take care of patients with diabetes a lot better. Neda received her MD degree from the University of Tehran, then came to the United States to do her house staff training at Michigan State University, went to the University of Arkansas to do her fellowship training, and stayed on at the University of Arkansas during the early part of her career, and then we were very fortunate to recruit her here in 2008, 2009 as a faculty member. As a faculty member here, as I mentioned, she has done a superb job not only taking care of patients with diabetes, but learning a lot more about how to manage patients with diabetes by doing industry-based trials, but also being funded by the NIH and the VA for her research. She's also played a very prominent role in the American Federation for Medical Research, the AFMR, serving as president of the AFMR and leading the meetings at Carmel for a couple of years. It's very fitting for Neda to tell us about an update on diabetes and help us take care of patients with type 2 diabetes a lot better. Let's welcome Neda to the podium.
Sorry. You're fine. Okay. Good afternoon, and thank you, Dr. Schwartz, for your kind introduction. I'm going to talk about diabetes management, as it was mentioned. And I start with my disclosure. As Dr. Schwartz mentioned, I've been involved in several clinical trials and received funding for research, and also worked as advisor. So the outline of my talk is mainly focused on new guideline published by American Diabetes Association and European Association for the Study of Diabetes recently. This guideline was even endorsed by American College of Cardiologists, and it changes our practice in diabetes care. So in addition to reviewing the guideline, I also want to review the evidence supporting this change in the guideline. And at the end, I will wrap it up with a case presentation to show how to implement these new changes in the clinic. So start with the first slide. Is kind of eye-opening statistic about diabetes. We have about 30 million Americans diagnosed with diabetes. 10% of population have diabetes. And the cost of diabetes is more than 300 billion with B nationwide. So we spend about 1 out of 5 healthcare dollars in diabetes, and the cost of care for a patient with diabetes is 2 to 3 times more than patient without diabetes. And there is only about 7,500 endocrinologists nationwide. So we really cannot take care of all of these diabetic patients, and it's very important for internists, subspecialties, know how to take care of diabetes appropriately and efficiently. So I would say this is one of the most important ground rounds because everybody should know about diabetes care. So starting with pathophysiology of diabetes, there are several organs involved in pathophysiology of type 2 diabetes, which is characterized by hyperglycemia. We have decreased insulin secretion to compensate for insulin resistance. We have a problem with hepatic glucose production. And also, incretin system that I will talk a little bit more is impaired in patients with diabetes. There is some new roles of CNS in diabetes and pathophysiology of hyperglycemia, which a new study has shown that CNS can control hepatic glucose production or incretin system. So along with so many abnormalities causing hyperglycemia in diabetes, we have so many treatment and interventions, which is great. For every single pathway, we almost have a class of medication or more than a class to compensate for this pathophysiology. For example, we have insulin and insulin secretagogue working on increasing insulin secretion. We have insulin sensitizer like TZD to compensate for insulin resistance, especially at the level of adipose tissue and muscle. We have GLP-1 receptor agonist and DPP-4 inhibitor as an incretin mimetic. We have good old metformin to kind of improve the increased hepatic glucose production. And last but not the least, we have SGLT2 inhibitor that help with increasing glucosuria and decreasing hyperglycemia. So many medication. We have almost 12 classes of anti-diabetes medication. And when you look at different preparation, different drugs, each class has several drugs, we have more than 100 choices for our treatment of hyperglycemia. It can be very intimidating and confusing. And the cost is so different. Some of the medication like sulfonylurea and metformin will cost us $4 per month. Some of the medication will cost several $100, up to $1,000 a month. So one of the take-home messages is not always the most expensive medication is the best for certain scenario. For those of you who are into the cars, if you drive your Porsche in a very congested highway, you're not going to get any further than other cars. So it's very important to choose the right tool for the right time, right place. And that's what the art and science of diabetologists is. Not all of us drive Porsche. So looking at guideline, this is the most important slide of today. And I'm going to focus and mainly talk about this guideline. What is changed is this left side of the guideline, that for patients who are not at target after metformin and lifestyle modification, you need to see what other factor and comorbidity they have. If they have cardiovascular disease or chronic kidney disease, it is recommended to start newer anti-diabetes medication. But if the answer to that question is no, then there is more options that you can consider. So I'm going to talk about this guideline more in detail. But before that, I want to talk about A1C of target. Because the first thing is if your A1C is above target, you have to add medication to metformin. But what is target? Again, American Diabetes Association and European Association gave us a recommendation in 2015 more in detail how to pick individualized target. And it totally depends on patient comorbidities and other factors, including duration of diabetes, risk for hypoglycemia, and age of the patient, potential for hypoglycemia, how motivated is your patient, and whether they have resources and insurance to cover for a newer medication. Depending on that, you choose your target. For the younger, healthier patient who doesn't have comorbidity, you need to go for tight glycemic control and very intensive target, lower target. But the patient who has comorbidities, with a short life expectancy, you can have less stringent target and you don't have to go down as low as, let's say, less than 7. But fundamental of treatment for hyperglycemia is to prevent hypoglycemia. You know, you cannot push for treatment of diabetes if you cause hypoglycemia because that can be immediate danger to patient and people around them. And A1C is a great tool for as a marker for hyperglycemia, but it doesn't tell you anything about hypoglycemia. So you, as a provider for patient with diabetes, you need to proactively, continuously ask them if they have experienced any hypoglycemia. And another overarching goal I will see for A1C, I like this statement the best. A1C should be bring down as close to normal as possible without causing hypoglycemia. That covers everything, because if you cause hypoglycemia, you need to back off, no matter where your A1C is. So that was the ADA and EASD recommendation. But last year, American College of Physicians came up with a new set of guidelines for A1C of target. And I want to briefly touch base here because it has created a lot of debate in this kind of field of diabetes management. ACP said, all of the patients, when you treat hyperglycemia, you need to kind of balance between harm and benefit of hyperglycemia treatment, which makes sense. For every disease condition, we balance that. But more specifically, they said most of the patient is okay to keep their A1C between 7 to 8. And if a patient has A1C less than 6.5, you need to de-intensify, raise A1C, because you might put that patient at harm, and harm is more than benefit. And they also said, based on age, if somebody is more than 80, you don't have to set target. It's enough to eliminate symptom of hyperglycemia. We don't agree with that, actually. We say most of the patient, and this is a couple of papers, one of them actually led by Dr. Drasnan sitting here, that most of the patient you can safely bring A1C to less than 7. So saying that most patient is okay to set the target 7 to 8 is not based on the evidence we have. And also, de-intensifying treatment or decreasing pharmacotherapy in patient who has A1C less than 6.5, we don't agree. And I give you a couple of examples. If you have a very young person with history of diabetes for 2-3 years on metformin that doesn't cause hypoglycemia and A1C is 6.4, you don't have to stop metformin or decrease the dose. I mean, the benefit is more than harm to continue. The other thing is, if you have an 81-year-old totally functional, active, A1C is 8.5, you don't say that because the guideline says anybody older than 80, I have to forget about A1C of target. So these are a couple of things that I want to bring to your attention about target. Now let's go back to guideline, the new changes in guideline. If a patient has CVD or a patient has CKD or CHF, you should start newer anti-diabetes medication. And what we are talking about is specifically SGLT2 inhibitor and GLP-1 receptor agonist. And for the next about 30 minutes, I want to go through all of the trials that support this change in the guideline. So the first class of medication is sodium glucose cotransporter 2 inhibitor. So this class of medication blocks a cotransporter, which is mainly in the proximal tubule of the kidney. It blocks reabsorption of the glucose and decreases hyperglycemia by continuous glucosuria. It's effective, lowers A1C. It also causes weight loss because continuously you are losing calorie through glucosuria. So what we have in this class of medication, we have 4 medication: empagliflozin, canagliflozin, dapagliflozin, and ertogliflozin. So you can see they are all end with gliflozin. And all of these medications are FDA approved and used in the US. And all of them got approval within past 10 years. The new recommendation of FDA that was published in 2008 was every single new anti-diabetes medication should be tested for safety. So all of them should provide information to us that they are safe in regard to cardiovascular event. And some of these, or most of this trial also went one step further to show that they can protect patients from cardiovascular event. So the name I put on the top is the name of the trial for each single medication. And what they had this trial in common, they were prospective, double-blinded, randomized trial, this drug of choice versus placebo added to standard of care. And what is important to know is at the end of this trial, the goal was to have identical A1C. So the goal was not testing effect of tight glycemic control versus the standard that we had it before on cardiovascular event. It was the goal was to check whether this new anti-diabetes medication can change the rate of cardiovascular event independent of change in glycemic control. So since we don't have time, I'm not going to go through this trial individually, but I try to summarize them. The median follow-up was about 2 to 4 years in these trials. The last one, Vertis CV, we don't have the results, so I'm just focusing on the first 3 ones. The age of the patient, roughly, they were same, 63. The minority were women. Patients with established cardiovascular disease, the way that they recruited, at the end, they wanted certain event throughout the study. So they recruited patients who are at high risk for cardiovascular event. Either they had established cardiovascular disease or they had risk factor. And as you see, studies were different in the rate of established cardiovascular disease in their population. A minority of the patient, between 10 to 20%, had CHF or CKD. So what are the results? EMPA-REG study showed that if you treat patients with empagliflozin versus placebo, you can decrease the risk of cardiovascular event, which was primary endpoint of this study, by about 14%, independent on glycemic control. And also, you can decrease the cardiovascular mortality and risk of hospitalization for heart failure. That was a great news for diabetologists, that you give a medication, anti-diabetes medication, that's supposed to lower blood sugar, but you're preventing cardiac event or decreasing mortality. And to be honest, we still don't know why. So for this amount of change, we need to treat 62 patients for a period of a study which was 3 years to prevent 1 event. Next trial came out, CANVAS, on canagliflozin, and it showed very similar, that you can prevent cardiovascular event by using canagliflozin. And mortality was not different, but the change in the rate of hospitalization for heart failure also was positive. It reduced the rate of hospitalization. And you can read the number needed to treat. The last study that was published a couple of months ago, actually was on dapagliflozin, and to our surprise, didn't show any benefit in regard to cardiovascular event. It didn't change that one, didn't change cardiovascular mortality, but it decreased the risk of hospitalization for heart failure. So you might ask, what was different about this study? Is this class effect? Before DAPA study comes out, we all thought, oh, SGLT2, they are all beneficial. But DAPA didn't show that. So is it class effect? Is it the differences in the cohort? Still, jury's out. But the slide I showed you on baseline characteristic, you can easily see the difference in the number of patients with established cardiovascular disease. That in DECLARE trial, only 40% of patients, they had established cardiovascular disease. And the rest didn't have it, and they had only risk factors. So there is a meta-analysis. They put this data together based on presence or absence of established cardiovascular disease. And the first 3 rows up there are 3 studies that we talked. And you can see in almost all of them, if you have established cardiovascular disease, you can prevent cardiac event or major cardiac event by prescribing this medication. The dapagliflozin, the last one, it reaches 1. So even if you separate for patients with established cardiovascular disease, you don't reach significance. But the overall was, the hazard ratio was less than 1. In a patient who do not have established cardiovascular disease, that doesn't apply to EMPA study because they were 100% established cardiovascular disease, but it applies to CANVAS and DECLARE. You don't see any effect. So if a patient has risk factor, this medication cannot prevent any future cardiovascular event. It's not good for primary prevention. So we learn about the benefits of this medication, but what are the risks? I mean, you need to look at the harm, potential harm of this medication. This medication works through glucosuria, so there's always glucose in the urine, even at the setting of normal blood sugar. So they are at high risk of urinary infection, especially yeast infection in female. Because they can they have direct effect on glucagon-insulin ratio, they put patients at, especially high-risk patients, at high risk of diabetes ketoacidosis. And the interesting part is usually this DKA is not associated with hyperglycemia because of continuous glucosuria, so they have euglycemic DKA. And amputation is something that came out of canagliflozin study. The rate of amputation was twice in patients treated with cana compared to others, but it was not replicated in other SGLT2 inhibitors. Something that was also very serious potential side effect is this new thing that came out is post-marketing, is not based on clinical trial, is necrotizing fasciitis of perineum or Fournier gangrene. That can be life-threatening. So there were, in the past few years, I think it's 5 years that this drug is in the market, there are 12 cases reported. I found the prevalence of or incidence of this disease is about 1.6 per 100,000. So, and it usually happens in men. In this case, we have 5 women involved with this Fournier gangrene. So this is something we need to be aware of it and watch for it for any kind of infection. One other thing is when you want to prescribe SGLT2 inhibitor, you also need to look for the kidney function because they are not recommended for patients with eGFR less than 45, and even in dapagliflozin is not recommended for eGFR less than 60. So that's something to keep in mind. So let's go back to another class of medication, GLP-1. So what is GLP-1? It stands for glucagon-like peptide 1 receptor agonist. In normal physiology, in response to food, you have a small intestine releasing this GLP-1, and it goes to your pancreas, stimulate insulin secretion, suppress glucagon, it slows down stomach movement, and also it suppresses appetite. At the end result is decreasing hyperglycemia and kind of helping with glucose metabolism. There is an enzyme, transmembrane enzyme DPP4, that immediately, within 5 minutes of secretion of GLP-1, it inactivates GLP-1. So if you want to enhance this incretin system, either you have to block DPP4 or you need to give a GLP-1 to a patient that is resistant to this inactivation or resistant to the effect of DPP4. So let's talk about GLP-1s. So the first GLP-1 came with the name of exenatide. Actually, it was derived from Gila monster. It's a lizard GLP-1. That's why the homology with human is only 50%. So it's based on exentin 4. Okay, and it's relatively short-acting. After that, we have so many other GLP-1 came to the market. We have 6, 7 of them in the market, and some of them, 2 of them, which is exenatide and lixisenatide, are exentin-based, so homology with human GLP-1 is relatively low, is only 50%, and this is the exenatide long-acting with the brand name Bydureon, the same thing, but the rest are very very similar to human GLP-1. And the reason that the newer one are once weekly because of slow release. This medication, I forgot to mention, they're injectable medication, so you inject it under the skin, and depending on how slow they go to circulation, they can have longer half-life. When you bound this GLP-1 molecule with a larger molecule like IgG in dulaglutide or albumin in albiglutide, or same with liraglutide bound with albumin, or in the case of exenatide long-acting, is attached to a microsphere, polymer, then you make them longer-acting. There is semaglutide here that at the time of this paper was not FDA approved, another weekly one. So I brought up this exentin-based versus human-based GLP-1 because I'm going to talk about that maybe they are behaving a little bit differently. So what we have again, just bear with me a few minutes. I'm going to review all these 6 trials on GLP-1 and how they can change the cardiovascular outcome, and they can have any effects on future cardiovascular event. So there are 6 medications. The bold one, they are approved. We have the newest one, oral semaglutide, that is not approved yet. And the top line is the name of the trials that we have for each of them. Again, duration of study, median follow-up is different among the studies. N is different depending on the rate of event, how you choose your patient, whether they are high risk or lower risk. The sample size is different. And this is the baseline characteristic of patients. And the reason that REWIND and Pioneer 6 is not bold because they had a news release of their result, but the paper is not published yet. But we have these 5 studies published, and you can see that, again, going back to SGLT2 story, the established CV or CVD, cardiovascular disease, is different depending on the design of the study. It can be as high as Elixa, lixisenatide, 100% because they recruited patient after MI, or as low as 30% in REWIND for dulaglutide study. Okay, this is kind of the summarize of all of the CV outcome trial of GLP-1. To make it kind of short and summarize, the only one that showed cardioprotection was liraglutide, and the primary endpoint, which was a composite endpoint for non-fatal MI, non-fatal stroke, and cardiovascular mortality, was lower in liraglutide, driven by cardiovascular mortality. For albiglutide, was also lower, driven by lower rate of MI. Here we have semaglutide also showed some reduction, but I just want to bring to attention, that's very important to know that semaglutide was designed to show non-inferiority. It was not pre-specified, or it was not powered to show cardioprotection or superiority. Dulaglutide and oral semaglutide, we have news release. I don't have that much information. Dulaglutide claimed cardioprotection, and semaglutide, oral semaglutide, the result was only non-inferior and didn't show any superiority. So let's look at the leader. Leader is the one for liraglutide, and the reason I want to show it to you is to kind of see the difference of primary prevention versus secondary prevention of cardiac event. We don't have that much data to kind of tell us, or meta-analysis in GLP-1 to see if patients who have established cardiovascular disease will benefit better than patient with risk factor. At least that meta-analysis, I haven't seen it, but I can show you subgroup analysis in LEADER, that patient who had history of cardiovascular disease, they benefited more than patient who did not have any history of established CVD. And I mean, there is a significant p-value for interaction. So kind of going with the same notion that this medication would work for patients with secondary prevention. So we have this meta-analysis. I found that it will divide GLP-1 based on that their structure, whether they're exentin 4 base or human GLP-1. And what they showed here is those GLP-1 that are exentin 4 based, they actually didn't show that much improvement in cardiovascular event or superiority, but human-based, at the end, they showed protection. Is it the structure of GLP-1? They sit on a different receptor, affinity with the receptors are different, or the cardiovascular effect is different? We still don't know. So talking about side effect of this medication, GI side effect is a common one. 10% of patients stop taking GLP-1 because of nausea, vomiting, or a GI problem. Skin irritation at the site of injection. And the last one is pancreatitis, that we were so concerned about GLP-1 causing or increasing the risk of pancreatitis. We know for sure that amylase lipase goes up after GLP-1 injections, but whether it's really the incidence of pancreatitis is higher or not, we don't have evidence supporting that. All of this cardiovascular outcome study, they showed a similar rate of pancreatitis in GLP-1 treated patient versus placebo. But the point is they excluded all of the patients who had history of pancreatitis. So they excluded most of the patients who were at high risk for pancreatitis. So it's still jury is out whether we should give it to patients with history of pancreatitis or not. But the recommendation at this point is it's okay to give it to patient, and there is nothing in their package insert for contraindication. Only gastroparesis and history personal or family history of medullary carcinoma of thyroid is one of the contraindication. And it's just because of animal data showing that superphysiologic dose of GLP-1 cause medullary carcinoma of the thyroid. So let's summarize all of these findings. First of all, we show that empagliflozin, canagliflozin had moderate effect on prevention of cardiovascular event or MACE in patients who had established CVD, not on patients who did not have CVD. And independent on their baseline, whether they had CVD or not, they reduced the rate of hospitalization for heart failure. They also reduced the progression of CKD. But the problem is that when I showed you the baseline characteristic, only 10-15% of patients had CHF at baseline, and the CHF or hospitalization for CHF was not the primary endpoint of the study. So we need to consider that fact in our decision. About GLP-1 receptor, I talked, and I just want to make sure this is one of the take-home message, that even though we think semaglutide had a p-value which was significant for superiority, we still don't think that this is a cardioprotective medication. We don't have the evidence because the trial was not designed to show that. And only liraglutide and albiglutide showed superiority in regard to decreasing cardiovascular event. But the interesting thing is, before Harmony trial or albiglutide trial ended, GlaxoSmithKline decided to withdraw this medication from market. When the new CEO came, they said, we're going to focus on oncology. This is the same company that made rosiglitazone, if you remember. So they didn't have that much good experience with rosiglitazone, and they said, okay, we're going to, just because of the commercial reason, we're going to remove albiglutide. So we are left only with one GLP-1 at this moment that has shown cardioprotection, which is liraglutide. And all these three medications, liraglutide, empagliflozin, canagliflozin, they're all received approval by FDA for reducing the risk of cardiac event in addition of treatment of hyperglycemia. So it's in their package insert that these are the cardioprotective medication. So I usually do that, and I think it's a good way of having a better idea of prescribing this medication. I put number needed to treat for these three medications based on those three large trials. How many patients needed to treat to prevent one MACE? And I found the cost of, for sure cost is different based on insurance, based on where you look, but I found a website, goodrx.com, about the cost of medication, and this is the cost based on that website. And depending on the number needed to treat for the duration of the follow-up, you need to spend $1 to $2 million to prevent one MACE, just to have this in your mind. Again, these are the very expensive medications. Okay, so I provided you with guideline. I provided you with kind of data behind that, why we are choosing SGLT2 inhibitor or GLP-1 for patients who have established CVD. But let's practice on a case. And this is a case that I saw at VA, 67-year-old man diagnosed with type 2 diabetes about 10 years ago. Patient has some of the complications of diabetes, including peripheral neuropathy and also some CKD, maybe not just because of diabetes, multifactorial, but patient has CKD. Patient had non-ST elevation MI about 2014, 4 years ago. And like most of patients with type 2 diabetes, they have comorbidity of hypertension, dyslipidemia, obesity, and this patient has CHF and AFib. You can see the list of the medication. Specifically for diabetes, patient takes two medications, metformin and basal insulin. Patient is on statin, ACE inhibitor, and carvedilol, spironolactone for CHF, and patient is on anticoagulant for AFib. What is some of the exam and lab in patient? BMI is 45, so patient is quite obese. Blood pressure is at target. A1C 8.5, creatinine 1.6, eGFR 48, and LDL very close to target, if you believe in target, 73. When I take care of diabetic patient with diabetes, I always want to know their previous A1C, because just having a snapshot of A1C of 8.5 doesn't give me enough information. So actually I pulled, I don't know if you can see, A1C history of this patient since 2011. And this patient had, different color at VA just simply means that they changed instrument or assay. But patient had A1C at target for several years. In 2014, he comes with MI. A1C was very high. That's the time that he gets started on insulin, and he responds, but it fluctuates. And the most recent A1C is 8.5. I will see in this patient the target is much lower. The exact target probably closer to 7, less than 7.5, or maybe if I push it to less than 7 without hypo, I will be happy. So patient needs intensification of medication. What should I do? So many options. You remember we talked about so many options in treatment of diabetes. We can maximize the current regimen because metformin was 500 BID, insulin was 30 units, and you can go higher on insulin. You can add medication to improve insulin resistance. Patients morbidly obese can get pioglitazone. You can add liraglutide and empagliflozin that we talked about, or add sulfonylurea or DPP-4 inhibitors. So let's see what we should do. This is also, I want to walk you through that other parts of the new guideline, that what is the goal of care? That is kind of discussed a lot in this new guideline. The goal of care in patients with diabetes is to prevent complications of diabetes. I mean, as physicians, we are not treating numbers, we are treating conditions. So our goal is to prevent complications of diabetes and also to optimize quality of care. You don't want to, you want to create a balance between these two, because if you intensify treatment and you decrease the quality of life of the patient is not going to stay compliant with the medication. So it's very important to think about both of these at the same time, and you don't want to compromise either of them. So what is your treatment strategy? Again, adopted from the new guideline. It's very important to assess your patient because they keep talking about now individualized treatment strategy in this new guideline. Our previous guideline, the word on the street was individualized A1C. But this 2018 guideline, they are talking about individualized treatment strategy. What they mean? First of all, you need to assess your patient. There are several factors that can affect your decision. Then you need to consider, after that, consider a specific factor that might affect your decision. You come up with a plan. You discuss that plan. Plan should be patient-centered, and shared decision-making is very important. You need to talk to your patient. I'm going to start you on this medication. These are potential side effects. Are you on board? Are you going to take that medication? And then continuous monitoring, and the same cycle goes on and on in each visit, because patient might agree on a plan. Next visit, you need to again ask them, are you okay with this treatment? So in this case, we assess patient factors. Patient has high A1C, established cardiovascular disease, and patient is motivated, because it's very important for those of you who have seen and taken care of hyperglycemia in patient with diabetes. If patient is not motivated, doesn't matter. If a patient is not compliant, doesn't matter what you give them. The A1C is not going to improve. So this patient, denied history of hypoglycemia, overall is very motivated, enthusiastic to reach the A1C of target, and life expectancy is 10 years or more, so I need to push for A1C at target. Option number one, increase metformin from 500 twice a day to 1,000 twice a day. I will say don't do that, because with this eGFR of 48, the recommendation is keep lower dose. eGFR less than 45, even they don't recommend it, but it's okay to continue with the lower dose. So I'm a little bit hesitant about increasing the dose of metformin. But can I do it? Probably yes, with closer monitoring. Increasing the dose of insulin. It sounds like an easy option. You can, as a primary care or endocrinologist, say, okay, what is your fasting blood sugar? And patient says all of them are above 130, which is our target, 170, 150, 190. We'll say, increase the dose of insulin by a couple of units, and I will see you in 3 months. Another take-home message, always look at overnight drop in blood sugar. At the same patient, when you ask for checking HS or bedtime blood sugar, you will see that patient slept with a blood sugar of 300, woke up with 150. There is significant drop in blood sugar. So it already tells us that patient is taking too much of basal insulin, and you cannot treat your postprandial hyperglycemia with basal insulin. It causes hypoglycemia, nocturnal hypoglycemia. Fundamental treatment of blood sugar or diabetes is prevention of hypoglycemia, so watch for that. So you don't simply increase the dose of insulin without having all the information. So pioglitazone, is it an option? I will say in patient who has CHF and is already morbidly obese, I don't use TZD, even though I think that pioglitazone has an important role in management of diabetes. Liraglutide and empagliflozin, they are good options. I showed you data that can prevent future cardiac event, and this is a patient with established cardiovascular disease. So that's a to-go medication. But between these two, I have to discuss it with my patient. I have a pill that probably is cardioprotective. I have an injection. Which one you want to go? And I will talk about the potential side effects of this medication. Shared decision making is important. My patient comes back to me and says, I don't want to take more than one injection a day. One insulin is enough. I don't like injection. And we see a lot this inertia in the patient that for some reason they don't like injection as much as oral medication, even though newer technology, the pen pen needles are so small and tiny, but still with the concept of injection, patients have some sort of problem that we try to talk them through. So I was talking about that, and I want to bring up this new medication we have because I think this has a very important role in management of hyperglycemia. This is a combined GLP-1 and basal insulin. Okay, it's a fixed ratio, so like a lot of pills that we have combined and they are fixed ratio, we are a little bit uncomfortable with this limitation, but this will give you the advantage of one injection providing basal and basal insulin and GLP-1. We have actually two of them FDA approved in the market. One of them is combination of insulin degludec, a long-acting basal insulin, and liraglutide, come up with the name of IDEC-Lira. And the second one is Lixilan, lixisenatide, a GLP-1 with Lantus or insulin glargine, and they have their own brand name. So I said, maybe that's an option. You want one injection, I give you one injection, but two medications. So what is the data we have for this combined basal insulin and GLP-1? The first set of, I focus on IDEC-Lira. The first slide showed that IDEC-Lira, combination of both, is better than each medication individually, which is not that exciting. And then the second slide, our second study shows that combination of basal insulin and GLP-1 is better than basal bolus. So if you have a patient on basal and you want to decide between basal bolus versus combination, you can gain the same A1C, but less hypoglycemia, weight loss as opposed to weight gain with basal bolus. Overall total daily dose is less with IDEC-Lira, similar fasting blood sugar, and better postprandial. So that's really good for a medication which is one injection a day versus 4 injections a day. Similar A1C, lower rate of hypoglycemia, less weight gain. So I discussed this option with the patient. I go back to our VA formulary. He said, forget about IDEC-Lira. We don't have it here. So a patient is not willing to take more than one shot a day. We end up doing empagliflozin for this patient. But empagliflozin is contraindicated with eGFR less than 45. Our patient had 48. I said, okay, I still haven't passed that line, and I can do the close monitoring. And the reason EMPA is not approved for less than 45 because we don't have enough evidence. Whether it's efficient or it's not effective in lowering A1C, we don't know, and trial is ongoing. Okay. So I talked to you a lot about a patient who has established cardiovascular disease. So we covered the left side of guideline. The right side is not exciting and is exactly the same that was in 2015. If a patient doesn't have established cardiovascular disease, first what do you do? Individualized treatment by asking, is patient at risk for hypoglycemia? If the answer is yes, you eliminate drug that has hypoglycemia as a potential side effect, which is sulfonylurea. So you end up with 4 different options, and then you can add and intensify further. But, I mean, it's a very difficult question because for none of our type 2 diabetes patients, we want to cause hypoglycemia. So we should wait for a patient to experience a bunch of hypoglycemia and then decide avoiding that medication. Number 2 question. Is the patient morbidly obese or weight gain is a problem? Yes, this is a problem for almost all of our type 2 diabetes patients. And if the answer is yes, you're supposed to start medication that causes weight loss, which are those 2 new medications that we talked, SGLT2 inhibitor and GLP-1 receptor agonist. These are the only 2 medications that cause weight loss in patients with type 2 diabetes. The last one, and the most important one, does the insurance cover the newer one? Or is the cost a main issue? Yes, it is. I mean, we don't want to bankrupt the healthcare system, but if the cost is an issue, you're supposed to choose sulfonylurea or pioglitazone because they're older medication, they cost $4 per month, and they still work. I don't have any objection. They still work. They lower A1C, they take you to target. It's kind of that Honda versus Porsche. Both of them take you from point A to point B, but it depends on different conditions. Okay, I thought it's important to see what happened in real life. This is some data, actually, I found it from EMR. Now, US has started kind of going through their insurance data or EMR or insurance claim and provide us with some information that European people used to do, or they are still doing it. So this is based on EMR data of Centricity and EMR, and they looked at 1 million patients to see what is the first line of treatment for patients with type 2 diabetes. And the green column here is metformin. So after all of this maybe more education, more training for providers, people are using metformin more frequently as a first-line treatment. So there is no point on choosing sulfonylurea or other medication if patient doesn't have contraindication to metformin. So about 77% of our patients, they have metformin as a first-line treatment. But the important question is, what is second line? That's the burning question, what we should do after metformin. And they haven't separated this database based on established CVD or no history of CVD. This is just all comers. I found this data is interesting, and this goes up to 2016. So from 2005 to 2016, about 11 years follow-up. And sulfonylurea, the blue one, is still the first line for, or a first medication after metformin. But their use has come down significantly. Potential for hypoglycemia, maybe that's the reason. And then the thing that has replaced sulfonylurea, I will say, is DPP-4 inhibitors. DPP-4 inhibitors we are using more and more. Is a safe medication. I want to call it low-maintenance medication. Doesn't need that much adjustment, doesn't have side effect. You prescribe, go home and take it. You don't have to call patient again and again, ask for potential side effect. But unfortunately, they are not effective that much. The A1C lowering is 0.8. So you're paying a lot for a low-maintenance drug. Lowers A1C, but just a little bit. And I have the same data on UK. This is the entire UK population. And this is specifically asking what physicians are doing in regard to second medication after metformin. The pink column is TZD. We used to, or in the UK, they used to do a lot of TZD as a second line, which is insulin sensitizer, the strongest and more effective insulin sensitizer we have in the market. But 2008, you remember all the meta-analysis that came out that rosiglitazone might kill your patient, might cause cardiac event, which happened to be not true. It lowered the use of TZD. We still don't use TZD that much, even though more data show that TZD increases risk of CHF hospitalization, but it doesn't cause MI. This blue line is a sulfonylurea, and you will see that the blue column, that the use of sulfonylurea even in the UK has come down. And this line, this color is DPP-4, that people are using DPP-4 a lot more. So answering the question, what is the best treatment after metformin in patients who do not have history of CVD, still is going there, and we have so many options because we don't have any evidence or data supporting one over the other. And this is a GRADE trial. I'm one of the investigators of GRADE, and is NIH sponsored. We have 5,000 patients randomized to one of the medication after metformin to look to see which medication can sustain normal glycemia or sustain euglycemia longer period of time. And one of the arm is sulfonylurea glimepiride. Second one is sitagliptin from DPP-4. We have GLP-1 and we have insulin. This study started 2013, and we are at year 7 and 8, or 7, 6, 7. At the time, SGLT2 was not FDA approved. And that's the biggest limitation of GRADE, because that's the best study, comparative effectiveness of 4 different medication. But since we don't have SGLT2 in it, when it comes out, the result comes out, we are still missing a big question whether SGLT2 is bigger than any of these 4 medication. Okay, I want to summarize quickly. I showed you data about how bad is diabetes in regard to the high prevalence and also high cost of diabetes. I also talk about this decision circle. It's very important that you need to have patient-shared decision-making. You cannot just, some of us maybe don't like taking care of diabetes because it's hard to discuss your thought process, your decision with patient, wait for them to see what they want, what they don't want, but this is the principle of treatment. You need to share your decision with patient, otherwise compliance goes down. We discussed and we went through the changes in guideline, because now it's very important. The first question comes to your mind after metformin, choosing medication after metformin, is if the patient has history of established CVD. If they have it, you go to a newer anti-diabetes medication. This is a huge change. So we went through this guideline, and also we talked about always the most expensive one is not the best one. You need to find the right place, right time, and right patient. So I don't know if you watched Bob Ross before, but he always, I watched some of the episodes, and one of his quotes is, all you need to paint is a few tools, a little instruction, and a vision of your mind. And he called it the joy of painting, that sitcom that he had. I think the same thing applies for diabetes care. I'm really passionate and enthusiastic of providing the best care for our patients with diabetes. So I will say all you need for treatment of hyperglycemia is a few tools. We have a bunch of them. I talked through that. A little bit instruction and a vision in your mind. And I'm hoping that I provided some instruction at least today. Open for questions.
Neda, that was fantastic. Questions? Is there a question in the back? No. Let me ask you a quick question. The SGLT2 inhibitors, I was surprised to see that they were effective in individuals with established atherosclerosis not progressing or decreasing the progression, but they weren't effective in preventing the development. Was that a study power issue? Were there enough endpoints in the individuals without atherosclerosis, or is there some biological, physiological effect of SGLT2 inhibitors that would...
So the question is, like for SGLT2 inhibitor, we show that they are effective in patients with established CVD, but they are not that, they didn't show any benefit in patients who do not have established CVD. Is it simply a power problem, or there's something more in the physiology of the disease? And this is a very difficult question. The short answer is we don't know. But in regard to power of the study, all of these studies are event-driven. So they powered based on the number of the events to show some superiority. So I don't think it's simply a power problem. But to answer that question better, it's important to study a group of cohort of the patients specifically who do not have established cardiovascular disease. And we had this problem and challenge in a lot of things in diabetes care that maybe because of the timeline of a cardiovascular event, when you have established cardiovascular disease, the chance of next event usually is way shorter, like 3 years, 4 years. But when a patient is only risk factor and doesn't have established CVD, it's possible that the duration of the treatment is play a more important role, and you need to treat that specific patient who is at high risk for a period of time or follow them for the longer period of time to see the difference. And we have the same problem with intensive glucose management versus standard of care, that because of the duration of treatment, we fail to show that intensive glycemic control prevent cardiovascular disease. So I think short answer is I think the duration of follow-up and exposure to medication. Yes, Dr.
Can you tell me if you believe we should be using insulin at all in older patients, and should we be using it as a third, fourth, or fifth choice rather than ever considering it as a second choice, given the preponderance of hypoglycemia, most of which is completely unrecognized? I have a second question, which is the cost to prevent one cardiac event was between $1 and $2.5 million. Do you think that's worthwhile?
Okay, the first question is easier to answer. The question was in patients who are elderly or overall, let's say patients who are at risk of hypoglycemia. Should we even consider insulin as a treatment second option, or we need to exhaust all other options? I will say, fundamental of treatment, again, is prevention of hypoglycemia. You don't want to create hypoglycemia. And if a patient who is elderly population are people that you don't want to cause hypoglycemia in them because, it could be life-threatening. Yes, that goes to the category of we should not use them, especially in a patient who is at higher risk. I don't say only age. I will say so many other factors, duration of diabetes, anything that put them at the risk of hypoglycemia, I will avoid using it and delay it. But am I going to stop giving insulin to a patient who is above certain age? Probably not. And the other point that you brought up, hypoglycemia is not easily detectable. What is happening in a patient who have recurrent hypoglycemia, they have unawareness. So you might have patient, and a lot happened to us that patient comes and say, Doc, it's not important. I had blood sugar of 40 and I didn't feel anything. Don't worry. This is actually the time we have to be worried that recurrent hypoglycemia eliminates all of those catecholamine release and responses. So it's not easy to detect all the hypoglycemia. Yes, those are the high-risk patients. I will avoid agents that cause hypoglycemia like insulin and sulfonylurea and try to use them later or if needed. The last question is difficult. The issue of, I will say, whether it's worth to spend $1 or $2 million to prevent one cardiac event, which includes mortality. Depends. Human life doesn't have a price. So it depends on how you think about it and whether it's right or... I don't know. I don't have the answer to that. If I have limited resources and I want to give it to cover more patients, probably I will avoid more expensive one. But unfortunately, our healthcare system is kind of going on a circle in a way that we are spending and spending and spending, and we rationalize our expenditure.
How does that number compare with other calculations for other disease treatments?
I will say, let's say, compared to a statin. Statins, number needed to treat is not that different, which is exciting for anti-diabetes medication. Cost is different. So cancer, probably we are spending the same thing to save one life. But prevalence is different. That's another thing, that prevalence of diabetes is so high, 30 million, that's the problem. Jane?
So thank you for that, and I hope we've inspired everybody that diabetes is the most interesting of all diseases and the most fun to take care of. I wanted to go back also to the same two questions that Bob was addressing. One is the number needed to treat and that particular calculation. And, you know, that particular calculation is for that particular endpoint. But when you're treating, remember, these are drugs that treat hyperglycemia. And so they're not, the only thing you're treating is not the hyperglycemia, is not the MACE endpoint. You are also treating for microvascular complications. You are treating for heart failure, treating for renal disease, and particularly with the SGLT2s, if you looked at number of hospitalizations prevented and did a true cost-effectiveness analysis, which unfortunately has not yet been done, you may find that there was a quality-cost benefit, and by all that health economics things, it's a good idea. The second question is a question we're getting all the time about treatment of hyperglycemia in the elderly or the frail population. They don't need to be old. Some 95-year-olds are pretty robust, and 60-year-olds are not. But the natural history of type 2 diabetes does not necessarily allow you to be that simplistic, because some patients will need some insulin in order not to run a blood sugar of 400, which is very dangerous. And so in the general population, you can answer that question by yeah. And the new ADA EASD guidelines suggest that the first injectable treatment should not be insulin, but should be a GLP-1 receptor agonist. Because it has the most ability to lower A1C without hypoglycemia. And my question is, sorry, I can't help myself. My question was how, if you think of things and present that number needed to treat at $1 million to $2 million, does that really affect how you're thinking every day when you give these medicines?
I think going back to right or privilege factor, that what we should do, if I have to take 1 million of people from point A to point A to point B, and I have limited number of budget, and I'm in charge of it, probably I want to take more people to point B rather than taking a few of them with plane and have the rest walk. But that's my personal opinion. I don't have any control on healthcare system here.
Neda, thank you very much. That was terrific.